Welcome back guys. Now in the first part of video we have completed the ovarian causes of infertility, and there we have clearly seen that anovulatory conditions are the most common causes of the infertility, and we have also seen what is the management of the anovulatory conditions. How we have managed? By giving the ovulation inducing drugs, and also we have seen what are the tests which are done to know whether the female is having any premature menopause. These are the 5 different tests which can be done to know whether the female is having good amount of ovarian reserve or not. For example, the diagnosis came that the female is having premature menopause. Now what's need to be done? Her ovarian follicles are not present. Now can she become a biological mother? No, she is not having any follicles in her ovary. Then the only option for her is that she can have a baby by getting a donor ovum. We'll be getting an ovum from the donor and fertilizing it with the partner's sperm or the husband's sperm, and we are going to keep this fertilized ovum in a surrogate mother. She have to go for the surrogacy. Now she cannot become a biological mother. Why? Because her follicles are exhausted, that she have entered into premature menopause. Okay. Now I have forgot to mention you 2 important points. What are they? Guys, all the tests of, please concentrate, all the tests of ovulation are performed on day 22nd of the menstrual cycle. Why? Because on day 22nd of the menstrual cycle, there is this maximum function of the corpus luteum and maximum progesterone levels will be there. And we all know that in the second half of the menstrual cycle, all the events of the second half of the menstrual cycle are because of the progesterones. Progesterones are maximum on day 22nd. So if I do this test on day 22nd, I will be getting the better results. So all the tests for ovulation are done on day 22nd of the menstrual cycle. Okay. Now if the female is having irregular cycles, then the test will be done 1 week before the menstruation. In a normal regular cycle females, the test will be done on day 22nd. But if the female is suffering with the irregular cycles, then in these females, these tests to be performed 1 week before the menstruation. Now let's discuss about the tubal factors of infertility. Guys, we have already discussed that the fallopian tubes will be affected in the conditions like endometriosis, pelvic inflammatory disease and genital tuberculosis. Now the fallopian tubes will be affected, and because of the inflammation in the fallopian tubes, there will be development of adhesions. These adhesions will block the fallopian tubes. Whenever fallopian tubes are blocked, the sperm and ovum, they cannot be meeting. So whenever the sperm doesn't meet the ovum, fertilization cannot happen, and how can the pregnancy happen? So what I'm trying to put into your mind is tubal blocks can lead to infertility. Now you are just suspecting that a female might be having tubal blocks. Why? Because in her history, she might be having pelvic inflammatory disease or endometriosis or genital tuberculosis. You are suspecting that she is having a tubal block. So what is the investigation of choice for tubal factors of infertility, or I can say, what is that investigation with which we can know whether the fallopian tubes are patent or not? The investigation of choice is hysterosalpingography. So you all know what exactly is hysterosalpingography. In hysterosalpingography, you are going to release a radio opaque dye into the uterine cavity. This radio opaque dye will be going into the fallopian tubes. Okay, so this radio opaque dye, it will go into the fallopian tubes and it will spill into the pelvic cavity. When it will be spilling into the pelvic cavity? Whenever there are no blocks. If no blocks are present, this radio opaque dye, it will be spilling into the pelvic cavity. Now what you will be doing after releasing the dye, you will be taking X-ray. So if there are no blocks means, you can clearly see the radio opaque dye, it is completely filling the fallopian tubes. For example, if there is a block. Okay. Now please concentrate here. Now in this diagram, here for example there is a block. Okay, there is a block in the angle of the uterus or the corner of the uterus. Now if you release the radio opaque dye, what happens? Radio opaque dye is going to enter into the uterine cavity. Because of the block, it cannot enter into the left side of the fallopian tube, but it can enter into the right sided fallopian tube. So in the X-ray, you can only see that the radio opaque dye is entering into right-sided fallopian tube, but on the left-sided fallopian tube, there is no radio-opaque dye. With the help of hysterosalpingography, we can clearly know whether the tubes are patent or not. So, see, hysterosalpingography, it's the investigation of choice. No doubt, hysterosalpingography, it's the investigation of choice for the tubal factors of infertility. But if they ask you, what is the gold standard investigation for tubal factors of infertility? The gold standard investigation is laparoscopy with chromoperturbation. Okay, so laparoscopy along with the chromoperturbation, which means you are going to keep a incision in the abdomen, you are going to put a camera into the abdominal cavity and you are looking directly at the fallopian tubes. You are getting a visual inspection of the fallopian tubes and you are going to release the dye into the uterine cavity. Same thing. So, chromo means dye. This dye is passing through the tubes, chromoperturbation, and you are looking the tubes directly. So, you can directly see, visually see that this dye is passing through the fallopian tubes and it is spilling into the pelvic cavity. So, this is the gold standard investigation. Why? Because you are directly seeing what is happening with the tubes. So, two very important MCQs. Now, after this, I have already said you, tubal factors of infertility means there are tubal blocks. So, in how many places tubes can be having blocks? Majorly, the tubal blocks are classified into three types: proximal blocks, mid-segmental blocks, and distal blocks. Okay, proximal block means the block is present near the angle of the uterus or the cornua of the uterus. Distal blocks means the blocks which are present in the fimbrial end. Mid-segment block means in the middle of the fallopian tubes. Now, important point, sir. Guys, please concentrate. What is the most common cause of a bilateral cornual block? The most common cause, repeatedly asked MCQ, is the most common cause is physiological spasm. Okay, it's a physiological spasm, which means whenever you put the cannula, one more important MCQ is, see, for performing hysterosalpingography, you have to release the radio-opaque dye into the uterine cavity. So, the cannula used for hysterosalpingography is 𝐒𝐿-Wilkinson's cannula. The moment you keep this cannula inside the uterus, because of the irritation and because of the irritation from the dye also, there can be physiological spasm of the cornua of the uterus. So, this is something physiological. So, the most common cause for the bilateral cornual block is physiological spasm. Why? Because we know the cornua of the uterus, it is acting like a sphincters. Okay. Now, but if they ask you, what is the pathological cause of bilateral cornual block? Physiological cause is physiological spasm of the sphincters. Pathological cause is, we know it is the genital tuberculosis. Genital tuberculosis will cause the bilateral cornual block. One important point I want to put into your mind. Guys, for example, in one condition, there is unilateral block. Okay, unilateral block. In the other condition, there is the bilateral block, which means both the sides the tube got blocked. Now, which condition will be operated, which condition is not operated? Guys, if there is a unilateral block, usually operation is not needed. We are not going to do any surgery. So, unilateral blocks are usually not treated. If there is only bilateral blocks, if bilateral block is there, only these conditions are treated. Okay, that's a very important MCQ you need to keep in mind. And what is the most common cause of bilateral cornual block? It's the physiological spasm. And most common cause of pathological bilateral cornual block, it is the genital tuberculosis. Now, after this, see, hysterosalpingography, with the help of this, we can not only know the patency of the tubes, but also we are getting the information about the uterine cavity. Am I right or not? Yes, the dye is entering into the uterine cavity and into the fallopian tubes. So, with the help of hysterosalpingography, you can know the fallopian tubes, the interiority of the fallopian tubes as well as the uterine cavity. For example, if there is any defect in the uterine cavity, can you get it on hysterosalpingography or not? Yes, absolutely you can get it. For example, see, if there is Asherman syndrome, what exactly is Asherman syndrome, guys? we already know it. Asherman syndrome means intrauterine adhesions or intrauterine synechiae. Now, if you have performed hysterosalpingography and this female is having Asherman syndrome, for example, what kind of appearance you will get? See, Asherman syndrome on hysterosalpingography will have honeycomb appearance. Now, if there is this polyp or fibroid, if there is polyp or fibroid, what will be happening? For example, if this is the uterine cavity and here is the polyp or fibroid. Now, the entire cavity is going to be filled with the radio-opaque dye. But in the area of the polyp or in the area of the uterine fibroid, there is no filling of the radio-opaque dye, which means in the X-ray, you will be having filling defects. So, filling defects are because of either endometrial polyp or submucous fibroid. So, with the help of HHG, you can know the polyp or fibroid which is present in the uterine cavity. Okay, what I am trying to put into your mind is, you can know if there is any problem in the uterine cavity like polyp or fibroid or Asherman syndrome. For example, if there are any Mullerian anomalies, the topic of congenital anomalies of the uterus, we have clearly seen that hysterosalpingographic appearance of biconvate uterus, uniconvate uterus, septate uterus. Though hysterosalpingography cannot diagnose what kind of Mullerian anomaly, but with hysterosalpingography, we can know that if there is any congenital anomaly, that can be shown up in the hysterosalpingography, but diagnosis cannot be kept just based on the hysterosalpingographic image. Okay. Now, after this, let's talk about the hysterosalpingography done on which day. See, this hysterosalpingography should be done on day 10 of the menstrual cycle. Why it should be done in the first half of the menstrual cycle, especially on day 10? See, for example, why the female is coming to our clinic? The female is coming to our clinic with the problem of infertility. Now, if you are performing hysterosalpingography on day 16, for example, if you are doing hysterosalpingography on day 16, day 17 or day 18, this is second half of the menstrual cycle. What if on 14th day of her menstrual cycle, she have ovulated and by chance the sperm meets the ovum got fertilized and this embryo, this fertilized embryo, it got implanted. So what I am trying to put into your mind is, if you perform hysterosalpingography in the second half of menstrual cycle, so this hysterosalpingography will disrupt the implanted embryo. Okay. So you don't know that she got fertilized this month. She also doesn't know she got fertilized. She is still thinking that she is suffering with infertility. She doesn't know that this cycle she got embryo fertilized ovum, she got this embryo implanted. She doesn't know and you also doesn't know. So you perform hysterosalpingography. This hysterosalpingography can disrupt the implanted embryo. So it should be always done in the first half of the menstrual cycle, preferentially on day 10 of the menstrual cycle. Now after this, let's talk about the blocks. Guys, I have already said you in which places blocks can be there. There can be a proximal block, distal block or mid-segmental block. Now let's see what are the causes of a proximal block. The most common cause of a proximal block is genital tuberculosis, and most of the time the block in the distal end are because of the gonococci. And if there is a mid-segmental block, means in the middle of the fallopian tube, most of the time this block is because of the tubectomy procedure or sterilization procedure by the doctor. So proximal block most common cause is genital TB, distal block most common cause is gonorrhea, and mid-segmental block the most common cause is a sterilization procedure like a tubectomy. Now how this should be treated? Now there is a proximal block because of the genital TB. How this should be treated? If there is a tubal factor of infertility, please listen carefully. If there is a tubal factor of infertility, can we perform intrauterine insemination? No, you cannot perform intrauterine insemination. Why? Because already the tubes are blocked. You are releasing the sperms in the uterine cavity, but these sperms cannot reach the ovum. Why? Because there is a blockage at the level of tubes. So intrauterine insemination is not done for a tubal factor of infertility. So what needs to be done here? The best option is in vitro fertilization. So proximal block, distal block, what we can do, it's the in vitro fertilization. But what about the mid-segmental block? If it's a mid-segmental block, that's because of the tubectomy procedure. Now she wants to get a pregnancy again. Now because of this sterilization procedure, she become infertile. She wants to become pregnant again. So what needs to be done? We have to do the re-anastomosis of the fallopian tube. We have to do the reversal of the surgery. So very important MCQs. Please concentrate for tubal block. For tubal factors of infertility, the best treatment, the best management is in vitro fertilization. But if the infertility is because of the tubectomy or sterilization procedure, what we need to do is reversal of the sterilization needs to be done. Or at the end of the day, if you want to keep one point in mind, the best surgery or the best management, it's not the surgery, it's the management. The best management for tubal factors of infertility is in vitro fertilization. Now, let's talk about the reversal of the sterilization. You just want to reverse the tubectomy, which means you just want to do the re-anastomosis of the fallopian tube. See, this re-anastomosis process, it depends on certain factors. For example, if the re-anastomosis is 𝐒𝐿-ischemic anastomosis, I am again anastomosing ischemic part of the fallopian tube to the ischemic part of the fallopian tube. If it is 𝐒𝐿-ischemic anastomosis, there are more chances of the success of re-anastomosis. Or if there is clips, I have done the tubectomy, not by cautery. I have done the tubectomy with just simple clips. What exactly are clips? You know what exactly are the clips. If I am using a clip, I can simply release the clip so that again tubes will become patent. So, surgery with clips will be having best outcome. So, clips can be easily removed so that she will become again fertile. So, MCQ is reversal is best with the clips. After clips, rings are best. 𝐒𝐿-ischemic anastomosis will have the best outcome. Okay. Now, after this, I have already said you the best management of tubal factor of infertility is in vitro fertilization. So, tubal factor of infertility is completed. Now, let's go with the uterine factors of infertility. Guys, what exactly I mean by uterine factors of infertility? There is some problem in the uterine cavity that is leading to infertility in the female. So, what and all those conditions? Guys, for example, if there are these Mullerian anomalies or congenital abnormalities of the Mullerian tract or the congenital anomalies of the uterus. For example, we have studied about bicornate uterus, uterus diidal phase, septate uterus, arcuate uterus. So, out of all these different types of uterus, what is that uterine anomaly most commonly associated with the abortions? So, abortions will cause the infertility. So, which Mullerian anomaly or which uterine anomaly most commonly associated with infertility? It is septate uterus, MCQ. Okay. Now, can Asherman syndrome causes infertility? Yes, Asherman syndrome means intrauterine synechia or intrauterine adhesions. So, these adhesions doesn't allow proper implantation. So, that can lead to infertility. So, what is the most common cause of Asherman syndrome, guys? The most common cause of Asherman syndrome is vigorous dilatation and curettage. Vigorous dilatation and curettage will cause the Asherman syndrome, and this Asherman syndrome can be responsible for infertility. And if you perform hysterosalpingography in Asherman syndrome, the appearance will be honeycomb appearance. We have discussed. Now, fibroids. How many different types of fibroids are there? We know that there are intramural fibroids, submucous fibroids that are intracavitary, submucous fibroids and subserous fibroids. So, if I ask you which type of fibroid is associated with infertility, it is submucous fibroid. So, submucous fibroid means, guys, please concentrate, submucous fibroid means a fibroid which is growing in the uterine cavity. So, these fibroids doesn't allow the pregnancy to happen. Okay, so very important point, submucous fibroids are associated with the infertility, and same like polyps also. Polyps also account for infertility. So these are the uterine factors of infertility. How to treat them? According to whatever the problem is there, we are going to treat it accordingly. Okay, so these are the uterine factors of infertility, and at the end of the day, let's talk about the cervical factors of infertility. So what is the exact problem with the cervix? See, in the cervix, there are these secretions coming. There is a cervical mucus. Sometimes this cervical mucus is very much thick. It's a very viscous mucus, so that sperms are not able to penetrate this cervical mucus and reach the uterine cavity. So, thick cervical mucus is also a factor for infertility. Or else, this female is making anti-sperm antibodies. So these antibodies are coming and residing in the cervical mucus. So whenever the sperms are coming through the cervix, these antibodies are killing the sperms and she is getting infertility. So what I am trying to put into your mind is, there is no proper receptivity by the cervical mucus, that is thick cervical mucus or viscous cervical mucus or impermeable cervical mucus, or there can be anti-sperm antibodies. So to know whether the cervical mucus is of good quality or not, so what is that scoring which we will be doing? It's the insular score. So insular score will tell you whether the cervical mucus is good quality or not. A score of 10 to 12 means good cervical mucus. And also, what about the anti-sperm antibodies? To know whether these antibodies are present in this mucus or not, the test which we will be doing is the SIMS test or Huner test or post-coital test. Repeatedly ask MCQ, post-coital test is done for knowing anti-sperm antibodies present or not. Okay, so in this test, what we will be doing is asking the couple to participate in the intercourse and come after some time. What we will be doing? We are going to collect the cervical mucus and we will see the interaction of the cervical mucus and the sperms which are present in the cervical mucus. Now, in this cervical mucus, if sperms are progressively motile, if they are progressively motile, there are no anti-sperm antibodies. But if the sperms are showing rotatory movement, this rotatory movement indicates the presence of anti-sperm antibodies. Okay, so these are very important points. So rotatory movement indicates the anti-sperm antibodies, and usually this post-coital test is done on day 10 to day 12. That's also the first half of the menstrual cycle. Okay, well and good. Now, how to manage cervical factors of infertility? Uterine factors of infertility, manage accordingly. Cervical factors of infertility, just think the problem is lying in the cervix. Now, what I have to do? I have to collect the sperms and I have to bypass this cervix area. I have to directly release the sperms into the uterine cavity so that these sperms will reach the ovum and fertilization happens. She will become the pregnant. So, bypassing the cervix means intrauterine insemination, sperms directly released into the uterine cavity. So, very important point, the management of cervical factors of infertility is intrauterine insemination. Okay, now at the end of the day, the last important point you need to keep in mind is, we know that unexplained infertility accounts for 10% cases of infertility, unexplained causes. So how to treat unexplained infertility? What is the management of unexplained infertility? The management here also intrauterine insemination. If you don't find out any cause in this couple, but still she is suffering with the infertility, so the management of unexplained infertility is also intrauterine insemination. So you are doing intrauterine insemination, but still she is not getting pregnancy. Try it again. She is not getting pregnant. Try it again. She is not getting pregnancy. So you can try this intrauterine inseminations for 3 cycles. If she is still failing to become pregnant, you can go for in vitro fertilization. So the management of unexplained causes of infertility is intrauterine insemination initially. If she is failing to conceive, go with the in vitro fertilization. We have completed all the factors of infertility, the male causes of infertility and the female causes of infertility. Hope the video is helpful. Thank you.